Comprehensive overview of intravenous, IV anesthetic agents. Welcome to today's deep dive, where we explore the fascinating world of intravenous anesthetic agents, the very foundation of modern anesthesia. This episode will break down their pharmacology, clinical applications, and the evidence behind their use. Let's get started. 1. Introduction. Today, we're focusing on IV anesthetic agents, drugs administered directly into the bloodstream to induce and maintain anesthesia. These medications offer rapid onset, precise control, and have revolutionized surgical care. We'll look at their main categories: induction agents like propofol and thiopental, maintenance agents such as continuous propofol infusions, adjuncts including benzodiazepines and ketamine. 2. Classification of IV anesthetic agents. Let's break down the main classes you'll encounter. A. Barbiturates. Thiopental. Thiopental, known commercially as pentothal registered sign, works by enhancing GABA-A receptor activity. It's a rapid onset drug, taking approximately 30 seconds to act, with effects wearing off quickly due to redistribution. Notably, it lacks analgesic properties and is best used for induction and electroconvulsive therapy, ECT. Keep in mind, it can depress both cardiovascular and respiratory systems, and it's contraindicated in porphyria. B. Imidazole derivatives. Etomidate. Etomidate is a go-to for patients with cardiac instability thanks to its minimal cardiovascular effects. However, its potential to suppress adrenal function makes it controversial, especially in sepsis. Side effects include myoclonus in about 30% of patients and nausea or vomiting. C. Phencyclidine derivatives. Ketamine. Ketamine stands apart with its NMDA antagonist mechanism, causing what's called dissociative anesthesia. Patients may appear awake, with open eyes and nystagmus. It's both an analgesic and a bronchodilator, making it ideal for asthmatics and trauma patients with hypotension. Watch for emergence delirium, which can occur in about 15% of cases, but is reduced with midazolam. D. Alkylphenols. Propofol. Propofol is the gold standard, prized for its rapid onset and short duration. Beyond anesthesia, it has antiemetic and anticonvulsant effects. Rarely, it can cause propofol infusion syndrome, PRI, a serious complication. Propofol's main side effects are hypotension and respiratory depression, and it can cause pain on injection, which can be mitigated with lidocaine. E. Benzodiazepines. Midazolam. Diazepam. These drugs enhance GABA-A activity, providing anxiolysis, amnesia, and anticonvulsant effects. Their onset is slower than others, making them perfect for premedication and sedation. Be cautious in the elderly, as they can experience prolonged sedation. F. Opioids. Fentanyl. Remifentanil. Opioids are potent analgesics, with remifentanil notable for its ultra-short action due to esterase metabolism. They are excellent adjuncts for pain management but can depress respiration and, at high doses, cause chest wall rigidity. G. Dexmedetomidine. An alpha-2 adrenergic agonist. Dexmedetomidine provides sedation without respiratory depression, ideal for ICU sedation or awake fiber optic intubation. However, monitor for bradycardia and hypotension. 3. Pharmacokinetics and dynamics. Let's briefly outline the key pharmacokinetic and dynamic properties of common anesthetic agents. Propofol acts quickly, with an onset of about 30 to 60 seconds and a short duration of 5 to 10 minutes. It's metabolized by the liver and cleared through both renal and hepatic routes. Thiopental also has a rapid onset, 20 to 30 seconds, and a short duration, 5 to 10 minutes, undergoing hepatic metabolism and redistribution for elimination. Etomidate takes about 30 to 60 seconds to work, lasting for 5 to 15 minutes. It is broken down by plasmodesterases in the liver, and eliminated renally. Ketamine's onset is 45 to 60 seconds, with effects lasting 10 to 20 minutes. The liver metabolizes it, primarily through the cytochrome P453A4 enzyme, and it is cleared by the kidneys. Midazolam is a bit slower. It takes 1 to 2 minutes to take effect, with a duration of 15 to 30 minutes. It is metabolized by liver enzymes, cytochrome P453A4, and eliminated by the kidneys. Remifentanil acts within 1 to 1.5 minutes, but its effects are extremely short-lived, typically 3 to 5 minutes. It is unique in being rapidly broken down by plasmodesterases and eliminated by the kidneys. These differences in onset, duration, and metabolism are important when tailoring anesthetic choices to individual patient needs and clinical situations. 4. Clinical considerations. Let's talk about how to choose the right agent and manage their side effects. Choice of agent. For cardiac instability, etomidate. For asthmatics or severe pain, ketamine. For rapid recovery, propofol or remifentanil. For sedation without intubation, dexmedetomidine. Adverse effects and management. Complications and their management. Propofol-induced hypotension. Treat with intravenous fluids and, if needed, vasopressors such as ephedrine ketamine emergence delirium. Prevention with midazolam prophylaxis as effective opioid. Induced apnea. Manage with ventilatory support and administer naloxone as indicated. Etomidate myoclonus. Can be minimized by pre-treatment with midazolam. Special populations. Elderly. Use reduced doses. Sensitivity is increased. Obese patients. Dose according to lean body weight. Except remifentanil. Renal hepatic impairment. Avoid thiopental. Adjust propofol doses for organ dysfunction. 5. Novel and emerging agents. As anesthesia evolves, so do our tools. Watch for ciprofol, a propofol analog, causing less pain on injection. Remimazolam, an ultra-short-acting benzodiazepine. Aliceridine, a Greek letter mu opioid agonist with less respiratory depression. 6. Summary of key IV anesthetic agents. Propofol is widely regarded as the gold standard for total intravenous anesthesia and day case surgeries, thanks to its rapid onset and antiemetic properties. However, clinicians should exercise caution in patients at risk of hypotension or propofol infusion syndrome. Thiopental remains a choice for rapid induction, particularly in situations requiring quick onset. Its use is best avoided in individuals with porphyria or significant cardiovascular disease. While less common today, it is well known for its affordability and historical significance. Etomidate is valued for its cardiovascular stability, making it ideal for patients with cardiac or hemodynamic compromise. On the other hand, it should be avoided in cases of sepsis or adrenal insufficiency. Ketamine stands out for its ability to provide analgesia and maintain cardiovascular stability, making it particularly useful in asthmatic patients or procedures requiring pain control. However, its psychomimetic side effects and the potential to elevate intracranial pressure warrant caution in susceptible individuals. Midazolam is excellent for providing sedation and inducing amnesia, though its use in elderly patients may be limited due to delayed recovery and prolonged effects. Its main distinguishing feature is the reliable production of anterograde amnesia. Remifentanil is a powerful option for total intravenous anesthesia and ultra-short procedures given its rapid metabolism by plasmaesterases. While effective, it should be used carefully in opioid-naive patients because of the risk of muscle rigidity. Each of these agents offers unique advantages and limitations, emphasizing the importance of tailored anesthetic plans for individual patient profiles. Conclusion. To wrap up, intravenous anesthetic agents shape the landscape of modern anesthetic practice. Each agent comes with its own strengths and risks, so mastering their use is vital for safe, effective patient care. Key takeaways. Propofol is the gold standard for induction and total intravenous anesthesia, but watch for hypotension. Ketamine offers stable cardiovascular profiles and analgesia, though psychomimetic effects can occur. Etomidate is ideal for cardiac stability, but avoided in sepsis. Remifentanil is perfect for ultra-short procedures and total intravenous anesthesia. Thanks for tuning into our comprehensive overview. If you found this podcast helpful, don't forget to like, subscribe, and share with your colleagues. Until next time, stay informed and practice safe anesthesia.